All right, Amy, ready to get us going?
Excellent. Yes, thank you. Good afternoon, everyone. It's the top of the hour, and I'd like to welcome you to our ECHO session today. Telemedicine and long-term and post-acute care facilities, keeping everyone safe. My name is Amy Schmidt, the Patient Safety Director at CoMagine Health with the ATOP program, which is the Centers for Medicare and Medicaid initiative, whose goal is to reduce unnecessary hospital transfers and improve quality and long-term care. We know how incredibly busy you are during this challenging time, and we appreciate your participation today. We know many of you are considering or may have already implemented telehealth services in your facilities, and we're hoping we can help facilitate that conversation, answer some questions, and share best practices today. First, a few housekeeping items. I know some of you have already just started to do this, so I'd like to ask everyone else who's joined to please introduce themselves in chat, entering your name, organization, and email. A couple housekeeping issues. You entered this session muted today. So when it comes time for discussion and or questions, you'll need to unmute yourself on the bottom left-hand side of your Zoom screen, or you can type a question into chat. Also located in the bottom of the Zoom screen. Chat will be moderated throughout our session today. And another reminder, if your video freezes at any point, you may want to consider turning your camera off. Just a little tip. This session will also be recorded and shared upon conclusion. Next slide, please, Trudy. I am proud to be joined today by an incredible team at CoMagine who helped put this session together and will be sharing their telehealth expertise with you today, as well as many, many others behind the scenes and working in our communities. So we've listed everybody's name here, but in the interest of time, we're going to move straight into what we're going to talk about. Next slide, please. So the ECHO model, as you all know, is a learning network that supports and accelerates change. So today we're going to have a 20-minute presentation on telehealth considerations and LTPACs, including a little Q&A, followed by 20 minutes of an interview-style format during which we'll ask longtime telehealth advocate, Dr. Stephen Phillips, your burning questions, and finally an opportunity for all of you in the session today to share your experiences about telehealth and ask questions of each other and of our team. Next slide, please. So let's get to it, and I'd like to turn things over to one of our internal telehealth experts, Trudy Bearden. Thanks, Trudy.
Thanks, Amy, for that wonderful kickoff. Thanks all for joining us today. So as a result of the public health emergency, CMS provided a waiver specifically for nursing home residents, and that is they waived the requirement for physicians/clinicians to perform those in-person visits and allow visits to be conducted remotely, which opens up huge opportunities for us. So we wanted to get a sense, kind of check the pressure in the room. Why are virtual services possibly a really great idea for LTPAC facilities and their residents? Let's do a little chat. So you folks on the line, what do you think are some of the benefits of providing virtual services in LTPAC facilities? As Sarah said, why are services important? Still able to speak with physicians. Awesome. So as we were preparing for this ECHO session, oh, awesome. Quicker assessment and treatment, save PPE. Yes, absolutely. So before we put this session together, we reached out to our numerous staff who interact and support LTPAC facilities, and we got a little bit of feedback from facilities. We heard it's a really great way to keep residents out of the emergency department and the hospital. So if somebody is starting to crump, those folks who are working in the LTPAC facilities, they know, they have this sense. And if they can get a clinician on the line and do telemedicine and keep a patient out of the emergency department in the hospital, it's good for everyone involved for reasons I don't even need to talk about. controlling exposure to and risk of infection, we don't want people coming into our facilities. And, we really want to cut down on infection control. So let's not have people come in. This is a really nice way to include people who have a health proxy or family, especially in some of the crucial conversations that seem to be coming up in the COVID time. Someone pointed out that this is a really great opportunity to have nursing staff working at the top of scope. So here's a real opportunity to elevate folks' scope of practice. If we're not transporting our patients to the hospital or to a clinician office, there's much less disruption for residents and staff. You don't have the time of getting the resident to the clinician's office. It can be, especially for our patients with cognitive impairment, having that disruption minimized can be a huge benefit. As you know, sometimes when residents come back from being out for whatever reason, it takes them sometimes a day or more to settle back into the routine and kind of recombobulate themselves. As somebody already pointed out, really great point, as Sarah said, reducing the use of PPE. As we know, this is a huge, huge issue. And there's some evidence that residents actually like this, as do families and the staff internally in our nursing facilities. And there is an opportunity to capture revenue. Our data analysts at CoMagin Health yesterday looked at, we wanted to know what are the claims looking like for people using telehealth? And so there's a lag in our data. We were looking at pre-COVID times. So we looked at July 2018 through June 2019. And we looked at those telehealth codes. And the one that we really wanted to look at is a particular code that lets us know whether people who are the originating site are capturing that revenue. And there was actually very, very few instances of use of that code. We'll talk about that in about 2 shakes. All right, so you all did a really great job of pointing out what might be some of the benefits in providing virtual services, what gets in the way. And we heard a lot about this from our line into the LTPACs. What we heard, for example, was, good grief, folks, we are in crisis mode. We are not even sure we have the staff for each day. We have people dying. Why are you hounding us about telehealth and telemedicine? And we get that. And just to be clear, we're not making the case either way on this ECHO session. All we really want to do is share information, no matter where you are along the spectrum, with adopting and supporting telehealth. So if you haven't even thought about it yet, maybe here's some information for you to think about whether this works and how this will work for you and your staff and your residents. Or you may be, you'd be like, been doing that, been there, done that for years and years. So, what gets in the way? Somebody put one thing in chat before I do the big reveal. What gets in the way of providing virtual services in the LTPAC setting? Change. Jennifer, thank you. Yes, lack of technology. Absolutely, absolutely. Provider cooperation, huge, huge. You may know or believe that this is the best way to go, but if you can't get those providers to join you in the change, things can come to a screeching halt. The other things that we have heard along the way, connecting to begin with. I heard about a man who had a urology virtual visit, and they sent him the wrong link. And he was like waiting. He's like, just waiting and waiting and waiting. He's like, oh, I guess the doctor is late. Or it's an unfamiliar process. You heard Amy talking about, oh, well, here's how you chat. Here's how you, here's how you can do whatever in the platform. we're not used to it. If we're not used to Zoom or we're not used to whatever the platform is, there can be a learning curve. Slow or low bandwidth connection, we're hearing this is a huge problem. Thank you, Connie. We're hearing that this is a huge problem, especially for our rural organizations and practices and residents and patients, because that's where telehealth really where the rubber meets the road. And in the state of Idaho, for example, if you do a telehealth visit and the bandwidth is and you have to, for the telehealth services, you have to have audio and video. If the video is glitchy, you cannot actually bill for that service. So this is a really big problem that we're hearing. We have also heard, especially when delivering behavioral health telehealth services, that some of those nonverbal language cues are missing. So you don't, especially if you don't have video, you can't see distress, you can't see tears. And even if you have the video, you may not see tightly crossed arms, tightly crossed legs. So you kind of lose that additional human piece that we get with in-person visits. Hearing and listening can be much harder. So it's harder for the clinician on their side, and it's harder for residents and patients on their side as well. It feels awkward. Why am I doing this? And the video can be glitchy. We use Zoom every day, several times a day at CoMagin Health. And sometimes we'll just get this weird echo, and it's so distracting. And so the audio can be glitchy. The video can be glitchy, and for those who have hearing impairments, it can be really difficult. Horror stories of hacked connections. Thank you, Fred. All right, so let's move on. All right, so one more. I'm going to call on our participants one more time. So if you are doing telehealth in your facility, what are you doing to support the delivery of these virtual services? Or if you're not already doing this work, what can you think of that you might be able to do to support or promote telehealth services in your facility? Sarah's call to action in the chat. What are you doing right now? Tamara, nice, using iPads, virtual visits for specialists. It sounds like we have some folks already delving into teleservices, facilitating using iPads. That's amazing. If we have time later, it might be interesting to be able to hear from some of you. So this is really awesome. So to add to what we saw in the chat, what we're hearing from some of the facilities is that preparing for the visit. So it's the LTPAC version of pre-visit planning or support. So, you know, what was the reason for the visit? Sending vitals to the clinician, sharing the residents' concerns. You could actually even put together part of the history of present illness. So for documentation purposes, the clinician has to document the history of present illness, but you can provide that information using the OPQRSTU mnemonic. I can post that in chat when I'm not presenting, but gathering the information to make the visit go quicker. So we're all efficiency experts. It's just hardwired into being a human. So really thinking about how can we make this as efficient and seamless as possible. Some organizations are using their nursing staff to be a scribe for the clinician. Now that we have a shortage of staff, I'm not sure that that's going to work for many people. But if, for example, the clinician, so another idea is if the clinician has Zoom healthcare and you can patch in family or a health proxy, there are pros and cons to that, so we're not going to go there. But this is a possibility. You could be the one who would patch in or communicate with the family member or caregiver. We have heard that some practices have a cheat sheet for clinician offices. who does what, so which services do they offer, what platform do they use, how do they do it, so that you know what your options are, which we'll talk about that in just a second. Remind the resident of their questions. So a lot of times when you have an elderly patient in an exam room, I find that what happens is that the clinician or the MA talks to the primary caregiver, and we really need to speak to the resident. And I come from experience. I'm a primary care clinician. I've worked in the inpatient and the outpatient setting, and I know that happens. And I have seen MAs and nursing staff been taken to task for not actually interacting with the resident, or the patient interacting with somebody else. So you can facilitate that on your end. Repeat information for the resident. You may have seen that folks will turn to their family member. It's like they're cued in to hear that voice. So repeat information for the resident to ensure better understanding. There are opportunities to take or send pictures with telehealth. So you want to make sure that you have a way to do that secure and encrypted. Confirm the orders and the treatment plan, of course, and just ensure understanding by all parties involved in the visit. So there's a whole slew of virtual care services that are in the toolbox of the clinicians. I don't think that the LTPACs need to know what all of these are. Just know that there's a huge list at their disposal. Some of them they'll be a little picky and choosy about, so virtual check-ins, e-visits, and the telephone E&M services. They have low reimbursement, but the Medicare telehealth services reimburse the same as if the resident or patient was seen in person at the office. You do have to have that interactive two-way audio and video. And if there was a color that I could use that was actually silver, I would have put a silver lining around Medicare telehealth services. For LTPAC, there's a wee little silver lining around telehealth services specifically. So for 2020, there are 101 codes that clinicians could use. With the public health emergency, CMS expanded this to 200 codes. So there's so much that can be provided by telehealth services. And you, the LTPAC, you are the originating site. You're the spoke. That's where the patient is. Where the clinician is, that's what's called the distant site. So here's the silver lining. You can bill this originating site fee that you bill the Q3014 code, and sure, it's a minimal reimbursement, around 27 bucks. And I could put cha-ching in big air quotes, like, is this cha-ching or is this not cha-ching? We'll see. When we looked at our data, I did see that there was one facility. If I read the data correctly, it looked to me, when we looked at the data that I mentioned that we ran, that one facility did bill the originating site fee, and when we added up the total, it was somewhere in the range of $21,000. So not a lot, but still, this helps cover some of the costs that the LTPAC staff do on their side to facilitate the visit between the patient or the resident and the clinician. So what's in it for you, right? So what's in it for me? So a few things that we've thought about that would be maybe helpful are those subsequent nursing facility care codes and services that are federally mandated. Those can be delivered by teleservice. So if your clinicians don't know that, maybe there's this opportunity to say, we love you, but we don't love you that much. Please don't come see us. Let's figure out a way to do this remotely. Advanced care planning is huge. I was on a ECHO session this morning, and they were talking about advanced care planning and how they're going through for each resident, they're going through to see whether the advanced care plan is written and in place, and do we need to readdress it, because even though somebody may be a do not resuscitate or do not intubate or a DNR, DNI, they may, what happens if they get COVID-19 and they need to go to the hospital? What do we do then? And just ensuring that advanced directives are done. And if you want your physician to do the advanced care planning and do the advanced directives by telehealth, the reimbursement for them is good. So for the first 30 minutes to do advanced care planning with one of your residents, the reimbursement is about $80. And if they go over that 30 minutes, it can be an additional $70. There's care planning for patients with cognitive impairment. We can do PTOT for your individuals with diabetes. Diabetes self-management training can be provided remotely if you have those people and services in your community and available. And then there are other things that you can do. As I mentioned earlier, you can share the images. So if you see somebody developing a skin lesion or a skin tear or something like that, or a decube ulcer, you can send pictures. You can send sequential pictures, like here's how it's looking today, here's how it looks a week later, better, worse, or the same. Specialty consults also can be done by telehealth. So there's a whole range of things that one consider are in it for our LTPACs. And I'm almost done. I only have a slide more or two, and then I'm really looking forward to handing it over to Dr. Phillips. And if you are a nonprofit LTPAC, there is money available from the FCC. And if you are a nonprofit and you want to do this application, we are happy to provide an hour or two of support to help you sort through. From what we understand, this application is not that difficult, but we want our LTPACs to get a piece of the pie. So if you are a nonprofit, please, let's grab a piece of this pie before it's gone, because it is going to be gone super duper quickly. A few resources for you. The American Medical Association came out with a really nice playbook. It's generally applicable. It's incredibly well done, so well done that I sent it to our Marcom folks, our marketing and communication folks. I said, check this out, how well done it is. West Health has a really nice telehealth guide. They put it together in March of 2019, so ahead of their time, but it is a great resource. CMS has published what they call a toolkit, but it's not particularly helpful. It's really basically the general practitioner guide with one reference to LTPACs. And then we also have a telehealth desk. So I'm going to pause for a second. If there are any questions, comments, musings, or experiences that you would like to share at this time, I'm going to pause here, and if not, we'll move right on to Dr. Phillips. Sarah, do we have anything in the chat that we should address? Questions?
Yeah, so I just want to put a finer point on the fact someone had asked, do virtual visits meet the regulatory requirements for physicians? And I think Trudy answered that question on her slide. It absolutely can, if you can get that set up with your clinicians. And then there was a question about who actually bills the originating site. So who is the person that bills that within the facility? And anyone who's had experience with that, we'd love to hear the answer.
So a call out for, if you are a facility, do you have coders or billers entering that G0314? And Sarah, I bet that Dr. Phillips could answer that. So do we have any other questions, or should we move on?
There was just another request to stick in the chat how to find the application for the nonprofit. If somebody could grab that link for them, we could put that in the chat for the FCC application. Or go back one slide, Trudy, and Rebecca can see that.
Rebecca, I will, when I'm no longer talking and I can do a little more multitasking, I will put the direct link to that information in chat. We're pretty excited about this opportunity, and our state primary care association, for example, has been submitting these for their health centers. And we haven't personally gone through the process. We are happy to guide you through it, keep you on track. We'll do whatever we can to support you.
So the last question is about how long-term care can and should support telehealth with hospice and home health. And I'm assuming, Megan, that is the folks that may come to your facility to do some ancillary care or hospice care. And I would say let's wait to have Dr. Phillips share, and then we'll see what questions come, and we'll make sure that Megan's questions addressed.
Perfect. Anything else, Sarah? Can I move us forward?
That's all I see right now. So we'll move on to the next section.
Awesome.
Excellent. Thank you, Trudy. Appreciate it. Lots of great information in there that, again, someone asked, we'll be able to share the slides and a recording a couple of days after, so you'll get all this information. I'd like to now introduce Dr. Stephen Phillips, an internal, next slide, please, Trudy, sorry. And an internal medicine specialist and geriatrician with more than 30 years of experience. Dr. Phillips is the president and CEO of Reno-based Geriatric Specialty Care of Nevada, providing care to Nevada's seniors with visits in the patient's place of residence in skilled assisted long-term care group homes as well as private residences. Dr. Phillips also serves as the medical director for the Northern Nevada State Veterans Home and Northern Nevada Senior Care Plus Medicare Advantage plan, which is supported by Renown Health. As well as he's also a consultant on our ATOP program, which I mentioned earlier. But the biggest reason he's here today is because he is a telehealth champion, and we so appreciate this opportunity, Dr. Phillips, to talk to you about your experiences. Thank you for being here today.
You're welcome. Thank you.
So Dr. Phillips, how did you start using telehealth for your patients, and why?
About 5 or 6 years ago, we started providing services to a nursing facility, Highland Manor in Elko, Nevada, about 300 miles from our home base of Reno. And after about 18 months of a clinician traveling each week there by car, came upon the idea of starting to use telehealth, telemedicine, and with a colleague out of University of Pittsburgh Medical Center. And we started about 4 years ago, originally in Elko, doing telehealth.
So can you tell us a little bit more about how one starts? Who were the right people to engage at the time when you kicked it off? And what were the easiest use cases to help sell the Highland Manor Elko on that, as well as sell the practitioners and the staff there that telehealth services were the way to go?
But the administration has always been very supportive of innovation in wanting the best for their residents, given that they're 5+ hours away from either Reno or Salt Lake City, and travel is not easy, plane or train or car, and so it was having really a supportive administrative staff that also was involved with the ATOP Innovation Award with Health Insight, now CoMagine. So it's having supportive administration, it's having supportive leadership within nursing and in the facility, which is critical for buy-in. And then it's having providers that are engaged in that practice. And since geriatric specialty care provides all the clinical services to over 150 residents at that facility, we didn't have too much difficulty convincing providers to get on board too. And it reduced the need to travel from Reno.
So can you talk a little bit more about the training that you did? I know at that facility in particular, you had perhaps the Cadillac of telehealth systems with the Karavi cart, right? But the training and the support that you needed to kind of kick it off and get everybody on board, what were some of the processes that you went through to get everybody versed in how to use the service?
Well, we initially started with just using the QAPI process at the facility, that the buy-in that telehealth was the way to go within the facility. We still have a provider who lives in the community, physician assistant, and a part-time physician. But we were looking at how we can cover some off hours, as well as when that physician is on vacation, how can we augment, supplement the role of the physician assistant. And so it was first with QAPI, and then the cart you mentioned, Karavi, which is from the University of Pittsburgh Medical Center Foundation. The team came out and did a 1-week training on site. So folks from Pittsburgh came into Elko, and we did ongoing training, and several of providers from Reno and support staff also went for those trainings.
You mentioned the off hours, and that was one of the questions we got from folks that had registered for today's session. Can you talk a little bit more about the benefits and what you've seen and how telehealth has really assisted in that regard?
But there's a lot that we can do by phone with knowledgeable, experienced staff in the facility. Though there are those cases, say some respiratory distress. This cart, we're able to do 12 lead EKGs with immediate visualization on our end, meaning in Reno. It can listen to heart sounds, breath sounds, because it's a Bluetooth stethoscope with this cart, and also looking at wounds. The ability to visualize or a swollen right or left calf is really an added benefit. It's also very supportive for the staff in the facility, which is something that's extremely important, is that there's nursing at the bedside with the resident that's being evaluated.
Yeah, that's one of the great benefits. Can you talk a little bit more about other benefits that you've seen for residents and for families as well as staff?
Yes, we're actually several times families will be on site if it's a scheduled visit, so it's not something off hour urgent response. If it's a planned evaluation, and it's been really helpful with determining goals of care, also discharge planning, to have the family involved at the same time. And then also we've been able to reduce need for transfer to the hospital, which in a community like Elko, there's one hospital, one nursing facility. So it adds a little greater oversight.
Excellent, thank you. How has COVID-19 changed how you and the clinicians working at GSC use telehealth services?
Well, because of the lifting of the waivers, I've tried to encourage local facilities to embrace telehealth, even if there is not reimbursement, because I think it's just an added benefit to distinguish one facility from another, or group of facilities from other facilities, especially in the off-hour times. That's never really taken off in the Reno market. Now with the waivers from CMS around COVID-19, which all of my contacts within CMS are saying that those waivers will certainly be around to the end of this year and maybe even into 2021. So it's changed for us that we can do that in local facilities. And I mean, you can actually do a telehealth visit with your next door neighbor if need be now. There's just no restriction. And the fact that we also do assisted living, group home, and private residence, so home-based primary care, that has used telehealth as well.
You cut out a little bit on the last statement, but I think we got the gist of what you were saying, Dr. Phillips. So talk to me a little bit about, I mean, the Karavi card is excellent, and I know you guys did great training at Highland Manor Elko, but for those folks that are right now considering, implementing telehealth because of COVID-19, what is the best advice you can give how they can quickly jump on board and be successful? What are your tips for ensuring that when they put their toe into this pool, that they're going to have a good experience and be able to get the best benefits for their residents as well as for their staff and the clinicians that are doing the services?
Right. There are several other options. I mean, do not have to be super high tech, as mentioned earlier, you need audio and you need visual connectivity in order to do telehealth and be able to bill for it. So maybe I'll just turn it over to Jeremy. Jeremy Phillips is head of business development with geriatric specialty care, and I know he's on, so maybe he can just maybe give some insight into that.
Yeah, excellent. Thanks, Jeremy, for joining us today as well. We appreciate it.
Yeah, you're welcome. Thanks, Dr. Phillips.
Uh-huh.
So yeah, as Dr. Phillips spoke and was touched on before, really all you need is video, audio to be able to achieve these visits. Our practice, we have like we do it two ways. We do Microsoft Teams because we have the healthcare version of Microsoft Teams. And so those patients and family members who have access to an email and would prefer to be on a larger computer and have that set up, we send them an invite through Teams, and they can, and then we do the telehealth chat. Requirements is make sure you verify the patient is who the patient is. So we have them show identity so that they can, we get that box checked by CMS. And then just note it, make sure you state everyone that was in the room at the time. And the other service we use is we use a service called Backline from Doctors First. And that service is better for patients who just want to use their smartphone, because we can just send them a text message, and all they have to do is click the text message, put in their first name, their last name, their date of birth, and it connects them via video to our providers.
Excellent. What's been some of the challenges that you all have had, and how have you overcome some of those challenges with regard to telehealth? Can you talk a little bit about that?
Yeah, so
go ahead, Joe.
You can, Dr. Phelps, I'll do it from the home-based side, and you can do more of the long-term.
Thank you.
So this is more skilled. From our private residence home-based, the challenges are technology, making sure patients and family members are up and ready and able to receive it. Since we are still actively going into the homes and assisted living facilities for most of our residents, we've started the process of tracking which patients and family members are even capable of accepting our visits via telehealth. But there'll be more to come on that, as it looks like restrictions are going to stay for the time being.
Dr. Phillips?
Yes, and so as Jeremy was saying, we are still going in. If it's a COVID naive building, which we just yesterday had the first group home go COVID positive in Washoe County, and who knows what other group homes and assisted livings might do the same. We have one nursing facility in Washoe County as well. So as this expands, if you will, or as far as presence of COVID-19 infection, then the use of the telehealth certainly increases. The other main objective of our use of telehealth is just to touch base. One of the slides that Trudy showed was chronic care management. It's a great way. I mean, any practices that do chronic care management, adding telehealth at times to that encounter is again, just gives that visual touch as well as the verbal touch.
Excellent, thank you. And just one last question before I open it up to everyone on the session today. What advice do you have for folks that are maybe a little bit hesitant about jumping in on telehealth, especially right now, given the crisis period that we're in?
I think it is a great opportunity for all of us to embrace the use of telehealth. As I said before, waiver or no waiver, I think there's just such a benefit that you can bring to our services as clinicians by using telehealth. That being said, the fact you can be reimbursed for it, what a great time to learn how to use and embrace telehealth. I do not see it ever really going away, and I'm glad about that. I think the restriction for so many of us in the past has been maybe some cost for the technology, along with only rural designations. Now that that has been lifted, I say, if you aren't doing it, you really need to. And if you can identify administration, nursing staff, or if it's an assisted living, group homes, and make it part of your quality improvement process. It's a great tool, and surveyors really like to know that telehealth is in a building. Has been my experience.
Excellent. Thank you very much. Now let's turn to everyone else. What questions do you all have for Dr. Phillips or Jeremy? Sarah, anything in chat?
Yeah, so thank you. So Dr. Phillips and Jeremy both, I think, and from the previous section of the presentation, there was a question just about home health use of telehealth and also hospice. So can either of you describe your experiences with those, and what are the potential avenues for having those kind of visits conducted in an LTPAC or in the home setting with telehealth? Any experience that you have?
Sure. The home health, when they're in seeing a patient in the home, wherever that setting happens to be, assisted living group, private residence, a nurse can help originate that telehealth visit. And it adds, again, in those more complex, difficult cases, being able to have a clinician and nurse connect at the same time. And it's super for the family and the patient that's being served. With hospice, we do a lot of hospice work. GSC's been involved with establishing 4 different hospice agencies over the last 18 years in Northern Nevada. And so hospice medical directors also can connect with their team in the home. So those are 2 really good opportunities. And one of the hospices locally, they use iPads, and they just connect back and forth.
It's great. And I know in Utah, we have talked about the challenge of being concerned about COVID positive, asymptomatic healthcare workers entering buildings. And I know in hospice, there's been a nice transition to ensuring those visits happen through telehealth where appropriate, when it's a consultative visit, and the licensed clinicians can initiate those. And another question that has come up, and welcome anyone, Trudy with her expertise, or Jeremy, can any other sites charge an originating fee besides the LTPAC? So could a group home or an assisted living center do that? And if anyone knows that answer, there's a question about that.
I believe you have to have a CMS, almost, you have to have a TIN. So private group homes do, but you also, I know in the nursing facility side, it's billed through the business office because they already have a relationship with CMS for billing for skilled services and also for non-skilled services. So that's as much as I know about that. So I'm not sure about group home assisted living.
Yeah, Trudy, that may be something we want to look up and send out to folks just to clarify. Yeah,
Sarah,
Mike. Mike. There's Mike. Yes.
This is Mike Silver. Mike. I can answer that, or I can refer you to the place I look for that sort of thing. There's a Medicare Learning Network resources on this sort of thing, and they list the eligible originating sites. Group homes are not included on that list. Skilled nursing facilities are. So, but the rule follows what Dr. Phillips was talking about. You have to be basically among the designated Medicare providers in order to do that.
Okay.
Group homes are not on the list.
Okay, perfect. Another question that came through was just regarding, does an LTPAC get an originating fee, or can they bill for a visit when a clinician physically comes on site? And I don't think that's the case. It's just the professional component that's billed, correct? So Dr. Phillips, if you go visit a nursing home, the nursing home doesn't bill for your visit. Is that correct?
No,
Okay.
they do not. I mean, at least not that I know of.
Yeah, no, I don't think that. So I think the benefit of telehealth is they're acknowledging the originating site fee. It acknowledges that you've got to connect and get that iPad for the patient and do the things that is supportive. So I think, to Trudy's point, this is a unique opportunity to get paid to do this work in this current climate.
And Sarah, if I could just add,
go for it.
Thanks. At the Northern Nevada State Veterans Home, because families cannot come into the building right now, we have iPads at each nursing unit. And so they use Google, not Hotspot, but Google, some service of Google, where families can dial in and talk with their father, mother, brother. And so they're also using it for telehealth when needed. So it's a good investment for the facilities. One, it's customer relations for residents back to their families that can't visit right now. At the same time, you can use it for telehealth. So maybe get 2 for 1 on your investment.
I love that. So Amy, another question that's coming through is integrating healthcare devices with telehealth visits. So blood pressure monitoring, temperature, skin rash, pain monitor devices. Anything you guys want to say about that? And I think Dr. Phillips has had a lot of experience with a fairly complex device. Anybody else who has experiences with those integrations, feel free to chat, or we can also unmute you.
Jeremy, do you want to touch on that, just with all that remote patient monitoring, RPM?
Yeah, sorry, I had to unmute myself. And I just put into the chat all the originating sites that CMS allows for.
Thanks, Jeremy.
Yeah, of course. So, so the originating, so remote patient monitoring. So we've been doing that within our practice for a couple of years now, with some of our high utilizers with diabetes, and we have some Bluetooth scales out in the homes and some of the assisted living facilities, and blood pressure cuffs, which then ties back into our chronic care management system that Dr. Phillips was talking about a little earlier. Sorry, what was I actually answering, Dr. Phillips?
People ask about RPM and how that might tie into telehealth and enhancing reimbursement.
Oh yeah,
I think you were going in the right field.
I was, and then I kind of lost my train of thought. So with RPM, so the way we're currently utilizing it for our patients who we monitor through RPM, now that's triggering a different risk factor that is upgrading them to like a telehealth visit within our practice. And so in one of the facilities, like Dr. Phillips just said, that tested positive where we were going physically, we're shifting to the telehealth visits in that instance, and those patients happen to be on our RPM system as well.
Excellent. And feel free to unmute if you have additional questions about that. Anybody else have comments on remote patient monitoring? Are there any brand names you guys recommend? I mean, it's okay. We're not going to advise any of them, but if these guys have experience with any integrating devices that they recommend. Anil was asking, Dr. Anil Kumar.
Jeremy, you want to go for that?
Yeah, I'm a big fan of whatever you're comfortable with, quite honestly. If there happens to be one that you're EHR, and there's a bunch of EHRs right now trying to quickly maneuver telehealth in this space, so that'd probably be step one. The systems we use, we're gluttons for punishment, so we like to apparently type patient names in multiple systems. I would advise probably against that. So that'd be step one, is I just reach out to your EHR, see if they offer a product. If they don't, And step 2 would just be whatever you're comfortable with. I mean, we use Teams because we were already on Office 365. And so we just got the healthcare version of it, which makes it nice too, because then it syncs to the provider's calendar on their phone, and the provider can just do the chat through their phone if they want.
Thank you. That's a great description of things we've all heard of in the common space.
And
want to
if you
just
also just,
yeah.
Sarah, I'll just say if you're on Epic, Epic Zoom, is also supporting telehealth, and so I know a lot of large systems have Epic, and then for Renown, that's what they're using is Epic Zoom, and it also syncs to your schedule for clinicians, and I think that's super important, is that you have that right there, and it also times for you. So often you want to build time into your visit as well.
Staying on the technology question, does anybody know if Point Click Care has any integration features? Is anybody aware of anything there? And again, welcome the crowd to answer as well as our experts. Okay. Dr. Phillips, maybe in your experience, again, with a demonstration project, et cetera, do you have any videos of a simulated visit so people could sort of see what it's like when people do a visit by telemedicine? Folks are asking if there's a video out there. And Amy, you may be aware, or other folks who are really working on this. Has anybody seen a demo so people could see what this looks like?
Yeah, we've never created a video. Though videos do exist, again, not plugging. I mean, it's part of Enterprise Foundation with University of Pittsburgh Medical Center, but Karavi, KaraviHealth.org, I believe, is that right, Jer? I think if you go to that site, they do have some videos, and their cart was really Steve Handler is the person behind creating this cart with colleagues at University of Pittsburgh Medical Center, and Steve is a colleague of ours on the Innovation Award to reduce potentially avoidable hospitalizations of nursing facility residents, and that it is called the Raven Project. We're called ATOP. He's called Raven, and they created the cart around the Innovation Award. So, but Jeremy will be able to get you, and he can put it out on chat, their actual link. I see he's working on it already. So that way you'll have it. And there it is, KaraviHealth.com.
Thanks, Jeremy. Excellent. And I just want to mention, for those who asked about Point Click Care, Fred Williams mentions his vital machines sync with Point Click Care. So within that facility, that's one benefit. So that's good to know if you're using Point Click Care. Excellent.
Awesome, great. Thanks, Sarah. Thanks, Dr. Phillips and Jeremy and everyone for your questions. In the interest of time, I'm going to move us on to our facilitated discussion where we can continue to ask questions and share with one another. Trudy, would you pull our presentation back up so everyone can see our questions?
Yes, it gave me 2 shakes. During the registration process, we received some really great questions. Thank you so much for taking the time to submit those questions. And one of them, as I get this back up again, Dr. Phillips, was, are there any suggestions that you could make around safe and clear communication with the PCP?
Safe and clear communication with the primary?
Yeah, so if you're an LTPAC, what are there any recommendations for communication with a PCP?
Oh, okay. So let's say, if I get the question correct or interpret it correctly, a facility wants to create telehealth, and how do you then engage to primary care? I really have found, if that's my correct interpretation of the question, making it a QAPI project. That's such a powerful tool, quality assurance, performance improvement. We don't call it QAPI. I sit on NCQA, and we're offended when people call it QAPI, it's QAPI. And if you make it part of the QAPI process, get buy-in from the medical director, and then get it out to the rest of clinicians. I have really not seen anyone who is resistant. And in this current time, there are many providers that probably have more time on their hands than they did before COVID-19, work-wise. You know, nationally, AMA just put out a survey. Many primary care practices have seen a 60+% reduction in revenue, therefore in patient volume, in the last 6 to 8 weeks. So it's a good time to get clinicians on board for the facilities.
Excellent, thank you. So now's the time for us to learn from you and from each other, and for you to ask any questions that may have not been covered yet during our session today. And a reminder about evaluations, we're going to send a link, post a link, I think, in chat. So if you guys would let us know how we did today, we would appreciate it. I'm going to kick us off by saying, I think our questions are on the next slide, Trudy, is that, am I right? Woo, I was right. So are you currently planning for and are using telehealth in your facilities? I know some of you have already mentioned what you're doing in chat, and I know that we have one participant on the line, Shirley Hardy, the DON at Lifa Saran in Hawthorne, Nevada. And she has been doing telehealth with their residents to support behavioral and mental health. And Shirley, I am hoping that you can take yourself off mute and share your experiences with us today.
Okay, now it says I'm unmuted.
You are,
Can you hear
Shirley.
me?
Thank you.
Okay, good. What I have found with our residents, some of the good things is we are a very rural area and we have access to clinicians we wouldn't otherwise be able to use because of the distance from where we are to where they would be. Some of the drawbacks that I have found with our residents is we have a lot of very cognitively impaired type residents. And so it's kind of difficult for the clinicians to get a good picture of them. We have to make sure that we send them their health history and the issues that are currently happening prior to them seeing the patients. And in some cases, it's really a good thing to have a family member present or staff members that are familiar with the patients themselves. The one thing that we have that is an issue in our particular facility, because we're small, is getting a location where we have privacy so those patients, you know, and the doctor can feel free to talk about whatever the issues are, because we have a limited number of rooms and it's an old building, limited space, so we don't have a lot of, I have to like bring them into my office and things like that so that we can have more private areas where they can speak freely, which still presents a problem because some patients are bedridden and that kind of thing. Yeah. Other than that, I think that it is a very good program. Like I said, we have access to people we wouldn't be able to have access to at all.
Shirley, have you expanded use beyond behavioral and mental health care post-COVID-19?
Yes, they were expanding it. We haven't had to use it much yet because we've only had 2 positive cases in the county so far. But they have fixed it outside so we can move it outside when we get to that point, or if we should get to that point, where they have put up a table outside and we have the iPad so that they could use it by sitting at a chair in a quiet area outside or actually using it in their cars.
Excellent. Thank you. And I know that the cognitive impairment came up in a lot of questions prior to when you registered for the webinar as well. Does anyone else have some thoughts about that, what Shirley was just mentioning? Thank you, Shirley, for lending us your expertise and your experiences. We really appreciate you taking the time.
So, Amy, do you mind if I follow up with Shirley quickly?
Please do.
Did I hear you right? Are you making it possible for people to come to your facility who don't live there and access telehealth from your equipment, from your parking lot, your equipment?
They have it supposedly ready to set up. We haven't actually had it out in the parking lot yet. We haven't had the need. We haven't, like I said, we've only had 2 positive cases so far.
But you're ready for that.
Yes, we feel like we're for that. We'll be.
That is exciting. That is, I'm really impressed. Thank you for sharing that.
No problem.
Hey, Shirley, this is Steve Phillips. Could you just describe for everyone the uniqueness of Hawthorne and how long-term care is attached to other services? Because I think that really lends to Mike's comment regarding expanding the service. Maybe just so they kind of understand what your footprint is like for clinical services in Hawthorne. That'd be great.
Well, we are actually a part of the actual hospital. The hospital, I think, has 11 beds to itself. Part of those are swing beds, and then I actually have 25 beds in the long-term care. And then we have a clinic that's attached in another building outside, but we're all like clumped together, and we serve pretty much the entire community.
Yeah, thanks, Shirley. I just wanted everyone to kind of get that, because you really, I mean, they were integrated well before we started talking about integration years ago. Living in Reno and knowing the Hawthorne area, I've always been impressed. So that explains how, if they have the technology in one part of their system, they can share it to others. So that's great.
Oh yeah, it's like we're like all one building, and we're we just have little niches. Would be like different units, I guess you'd say, in a larger hospital. But it works really well, and we've done really well. I think we've done really well. We had a flu epidemic prior to the COVID outbreak, and so I've had my residents and families on lockdown for more than 2 months now, and I didn't really get a flu outbreak in the facility. I've had no issues with COVID so far, knock on wood. And it's been hard. We use the video chats too for families and that kind of thing, which is helpful for those patients that are used to having family visits daily or weekly. I mean, it's really important to try and keep up their social side of things as well right now.
Yeah,
so, but I think we do a pretty good job here.
Thank you, Shirley. That's an excellent point. Thanks, Mike. Thanks, Dr. Phillips, for bringing that to light. Has anyone made any comments in chat, Sarah, they want to share?
Yeah, just a couple things. So for those folks that haven't yet been oriented to chat, on the bottom bar where the mute, stop video, there's a little button called chat. And if you hit that, you can type in questions. You can also feel free to unmute yourself and ask a question of folks. So just a quick reminder there. And then the questions, I think, Amy, something that's been coming up and Shirley just alluded to it, was how do we handle patients who have dementia and how to make this easier, and any experiences that Dr. Phillips or others can share. And then the other one would be hard of hearing, any solutions or ways that people are dealing with those challenges with communication.
Excellent, great. Anyone want to take themselves on mute, take a stab at those?
Well, I'll do the dementia. It really is important to have someone to help support in one, use of technology, but also often a surrogate provider of information. So that's extremely, so in the nursing facilities where, as we all know, probably half of the long-term care residents have some form of cognitive impairment, if not even greater than that. What we like to have well in advance are any medications, especially recent medication changes, and then any interpretation, by nursing. And we highly encourage operating at the top of your scope of practice, for all of us. So for nursing to be able to really give a good review of systems and also any symptoms that they're appreciating, with that specific resident or patient. So that's helpful. The hard of hearing, many devices, have, earbuds or even headsets that you can use that can help overcome some of the hearing difficulty.
Excellent. Thanks, Dr. Phillips. Anything else in chat, or does anyone else want to take themselves off mute? We can move to the next question. Some technologies were already mentioned today. Is anyone using any technologies for telehealth services that we haven't mentioned that they'd like to share? Someone has there's a question in chat. I think how can you involve family and staff and patients in a 3-way visit? Has anyone tried anything like that on the technology side that they could speak to?
So this is Jeremy. We have through Microsoft Teams, because you can have the multiple people up, just like Zoom Health. You can have multiple people up. You just have to invite them appropriately.
Excellent. Thanks, Jeremy. And we have another question in chat. How do you deal with HIPAA? For example, residents in long-term care that share rooms and can't be moved. Anybody want to take a stab at that?
Well, it is important, but and it's especially if both residents are unable to be moved, then that's, I can't say we've encountered that over the years we've been doing this. Though I always like to remind everyone of what is excluded within HIPAA. Exclusions within HIPAA are evaluating, determining care needs, and financial. So yes, you don't want to overtly share information, but when it comes down to those things, it's not a violation of HIPAA. Now, is it the most perfect, from a patient privacy standpoint? That would be different, but it's not a HIPAA violation. So I think that's just an important distinction.
Anybody else have any other thoughts or comments? It's a great question. What have been some of the biggest benefits for those of you that are using telemedicine or have started using? What have been the benefits you've seen so far? Dr. Phillips has talked about it. Shirley's talked about it. Anyone else who's actively doing telehealth services and the effect it's had? Looks like we're getting chat more on the HIPAA question again, Sarah.
Yeah, I think for folks, some creative ideas for how to noise cancel the roommate's ears or put on a show. We do have a comment from Fred Williams. He's using the telehealth option with Epic for providers that don't have that, and FaceTime for those who don't. And I've seen FaceTime and Google Hangout come through. We've also seen iPads, FaceTime, and Zoom. And I think just important right now, CMS is allowing non-HIPAA services, so FaceTime and things could be used. I'll just say my thought would be, yes, dip your toe in the water with those services that are low bar, but think about moving to something, a platform that is HIPAA compliant for the future as this becomes something you just do. So that's a comment there. Let me see what else there is. in our chat. Fred, do you want to share? Do you want to share about what you guys are doing? Sounds like you have a flexible model. Feel free to unmute yourself. All right. All right, we have another question from Howard Greatzer. Any bad outcomes using telemedicine that can be commented on? So I know that, this is Sarah Wilsey, and I work at the state level in Utah. And one of the things we've come across, and I think there will be more issues relating to litigation just as we use technology more. But in the early days, some of the telehealth cases that came out were actually not using telehealth when you could. There was a case where it was an option for a consultation that was not done that led to an untoward outcome. And so that was an interesting message to us saying, if we can do this, it's something we likely need to develop just because of the advanced quality of care that it will provide folks. But I welcome anybody else who have comments about litigation or concerns there.
Thanks, Sarah.
I'll just share. This is Steve. When this was like 1999, 2000, the University of Nevada School of Medicine received a significant grant and put trunk lines. This is way before fiber and magnetic waves and all that kind of stuff. So they put all these lines, you know, Elko, Hawthorne, made huge cost that was funded through a HRSA award, so Health Research Service Administration Award. And a colleague of mine, and I did some telehealth, telemedicine way before it was really even called that, or you could bill for it. But the chief of psychiatry, chairman of the Department of Psychiatry, was asked to do a consult on an individual in Elko, and no one let him know that person had paranoia and was afraid that the television was speaking to him until the consult occurred. So I guess that would be considered an untoward outcome. So make sure that you understand the needs of a patient before you hook them up for telehealth, telemed. So.
Thanks, Dr. Phillips. We have just a few minutes left, and I did want to touch on Patty Polina, who's one of our ATOP APRNs and an advanced certified hospice and palliative nurse practitioner, is on the line, and she has been immersed in advanced care planning tips via telehealth post-COVID-19. And I'm hoping Patty can share a little bit of what she's learning in all of the webinars she's been attending, because I know that's one of the topics that came up earlier that Trudy mentioned. Patty, any specifics you can share with us? Any little nuggets?
Yes, can you hear me okay?
Yep.
Okay. Well, the goals of advanced care planning haven't changed, but they've been more challenging when decisions need to be made, when we can't go into a facility. Certainly it's ideal to do these things in person, but there may be a new crisis happening with a patient, or a patient may need to pick durable power of attorney. The most important thing for all patients to have, and this has always been true, it's really apart from COVID-19, it's ideal for patients to have a healthcare proxy. And that is what advanced care planning has to do with advanced directives. Holds are for frail patients where this is appropriate. So don't forget the advanced directive and the healthcare proxy. And yes, these conversations can be held over currently with the waivers. They could be done with FaceTime or any type of platform.
Excellent, thanks, Patty. We just have 1 minute left. Are there any other final thoughts or questions in chat, Sarah, that we want to touch on? Then we'll move to our next slide.
Nope, I think we're complete. There's some good sharing on platforms that people have explored. I think Fred Williams is a really great resource for folks that are looking at different platforms. If Fred is willing to share his email. And again, just thank you. That's all, Amy.
Yeah, I would love it, Fred. I want to learn more about you training your transporters who weren't transporting to help facilitate telehealth services. That's amazing. I love that story. So if you want to speak to a real person about these things, we're happy to help. You just need to let us know. You can email your contact at Comagine Health. You can reach out to Trudy Bearden. Her email is on the screen right now. And we also have a telehealth help desk. So feel free to reach out to us. We are here to support you, and we appreciate all that you do and appreciate your time today and all of the conversation. So thank you so much. Stay safe, stay healthy, and we'll see you hopefully again soon. Thanks, everybody.